My friend and my colleague, Dr. Denise Smith. She's an adjunct professor of biology at Andrews University and instructor in the Berrien Reese Math Science Center program, which is held here at the university. And one of the unique things about our collaboration, Dr. Smith and I, is that our research group and our research involves high school students, undergraduate students, and graduate students. So we run the whole spectrum, and it's been a really exciting few years. It's probably close to 10 years or so, I think. She might remember more clearly. So Dr. Smith, the floor is yours, the time is yours.
Thank you. Actually, it's been 8 years.
8 years, okay, there you go.
8 years, yes, yeah. So I've been looking at glioblastoma. I started looking at how long I've been doing this. And we're looking at over 20 years that I've been involved working with glioblastoma. I started it with my my Ph.D. My mentor was using it as a model system for cell signaling. He was interested in platelet-derived growth factor, and I got into his lab because I was interested in cancer because my daughter had had leukemia, and so I was interested in working on the puzzle that is cancer. So yeah, I get to Andrews 8 years ago, and one of the graduate students' presentation was talking about some of the compounds that she had made for antibacterial, and mentioned that they were also anti-cancer. And I talked to Desmond afterwards, and that was the birth of actually our collaboration. And it's been going strong for the last 8 years. And like you said, yes, we do graduate students, we do undergraduate students, we have high school students in our labs, all working on glioblastoma. So we've looked at a whole bunch of hybrid drugs. My background's actually cell signaling, but when I got hooked up with Desmond, we kind of switched into more drug testing kinds of things. And we've looked at all kinds of hybridized compounds, all of which have some kind of anti-cancer properties on their own. We've looked at stilbenes, we've looked at a whole host of things.
This camera is looking right at me.
A recent publication that we ran into showed a connection between temozolomide, which is really the main chemotherapeutic for glioblastoma, a connection between TMZ and aspirin and a better patient outcome. And that kind of fueled this year's research. And so we're going to be looking at hybrids made with temozolomide in hopes that we can maybe overcome resistance, which is a really bad thing that happens, and it happens quite frequently with temozolomide in patients. They relapse pretty quickly with resistance to the TMZ. And so we're hoping that maybe these hybrids will maybe overcome that aspect of it, or just be better at whatever they're doing. So we're going to be doing a whole host of anti-cancer drugs that we've used in the past. We're going to hybridize them to TMZ with a major emphasis on non-steroidal anti-inflammatories, or the NSAIDs, of which aspirin is one of. So we've got a graduate student that's going to be leading this, and we've got 9 undergrads that are going to be on this project. So we're going to hit this ground running pretty good here. To tell you more about the chemistry part of it, I'm going to turn it back to Desmond.
Okay, very good. So yeah, we do have 200 grams of TMZ right now in our possession. And so that will allow us to do a lot of chemistry. And basically we are going to be modifying.
This is seminar.
Could we have everyone turn their mics, their sound, mute them? Yeah, mute your sound. Thank you. So we are going to be modifying TMZ. For those of you who know some chemistry here and have a familiarity with the molecule TMZ, it has a primary amide group, and that primary amide group is the handle that we will use to attach different types of drugs and of other molecules. So for example, as Dr. Smith said, one of the modifications would be with aspirin. And that's part of the reason why we call these hybrid drugs, because we are taking two existing known drugs and by covalent chemistry, by covalently binding them together, we form one different hybrid drug. So that's part of what we will be doing. There are a number of variations that we will be trying that will keep our students very busy. So in terms of what I want to move on to now is to get things going further, and we could ask questions in the chat. We don't have the Q&A up, but you could put your questions in the chat for the Q&A period. And again, people who are not speaking, could you mute your mics, mute your sound? Okay, so I first want to start by introducing my friend, Janet Ledesma. So Janet and I developed a relationship, a friendship, I think about 4 years ago. And at that time, I was initially unaware of her husband, Rick's brain cancer. But I think I vaguely remember one meeting that we were at, and we were sitting together in the back of the room, and she said she had to take off to go to Chicago or something. But it was to go to be with Rick. And I think it was somewhere around that time that our research group that Denise just talked about, Dr. Smith just talked about, also really started working more intently on glioblastoma. Our first two graduate students to work on that, Tendai and Priscilla, have graduated with their masters, a joint master's, if you will, that looked at both chemistry and biology. They are both now pursuing their Ph.D. program at, I think it's the Medical School of Wisconsin. I can't remember the exact name at this point, but they were the original glioblasters, the original students that were working diligently on this project. So it was sort of coincidental that our focus on developing these chemotherapeutics for glioblastoma came about the same time period, I think, at least my recollection, of me developing a friendship with Janet. So I want to thank Janet, my friend, who has a job here like I do at Andrews University. She is the Associate Dean. She is the Associate Dean in the School of Education. And one of the things that strikes me about this and other things that I've seen her do is that she is using the burden of this thing that happened to her, happened to her family, happened to her husband, and try to turn this burden into a blessing. And I think that that's one of the ways we could look at this meeting today, with her opening up her life, really, for us to be blessed by it, to learn some more about this vicious disease. So about 2 weeks ago, around August 24th, we were having a conversation. I can't remember exactly how it all went down and how it all started, but she eventually, that same day, sent what she referred to as a humble request to Drs. Lukas and Horbinski to speak to our students about the research about glioblastoma and so on. And what was really striking to me is that within an hour, within 1 hour, both doctors were like, I'm in. And this was, they accepted. It was a done deal pretty much that same day, that same time period. And this is what brings us here today. So I'm going to share my screen now with Janet, and she hopefully she'll be able to.
Well, good afternoon, everyone. We're really, really happy to be here. Need to be allowed to share my screen so I can share what for you. I would first like to thank Dr. Smith and Dr. Murray for planning this afternoon. And I especially want to thank my son, Christian, and our daughter, Ariana, who is on, Mrs. Ariana Lanyon. She's on, if she can show her face real quickly and everyone can see her daughter. For the students who are on, this is for you. That's my precious baby girl, Ariana. For the students who are on, this is a gift for you. I cannot tell you how busy both Dr. Lukas and Dr. Horbinski are. And for the gift on behalf of our family, thank you so much for consenting the journey of our students be here for us. I wanted to share my screen and
Dr. Murray, the feature is still disabled from the host.
Well, I think, yeah, Dr. Murray, I think you have to designate
Multiple participants can share. Okay, there you go.
Yep.
okay.
Perfect. We have it now.
You got it? Okay.
Yep. And I wanted to share with you a little bit about our journey, but I would like to do so from the context of, thank you. I wanted to share our journey with you from the context of it is not the end. And I do so in a very, very open way with you because in spite of the fact that we have gone through this horrific journey, my husband is still because he was able to, why and in which ways. Back in January of 2015, my husband was diagnosed with glioblastoma multiforme. I had never heard of glioblastoma multiforme. The surgeon who performed his surgery wrote on paper, and this is a piece of paper he gave me, Dr. Sikorsky, can you please write this down? Because I want to read about this cancer. And he wrote it down and he said, Janet, I don't want you to go on Google and research what this is about. Because the research is very grim and you're discouraged. My husband was still recovering from surgery. And of course, I had a lot of time on my hands. And as a researcher, what do you think a qualitative researcher would do? They would go on Google Scholar and look it up. And indeed, it was very, very, very grim. The prognosis my husband had back in 2015, 3 months to 15 months. His longevity was measured in terms of months. And we just celebrated our 25th wedding anniversary. How in the world could this be? And so I talked to Dr. Sikorsky and I said, please let me know what novel things are out there that we can try to help my husband just have one more day with my son, one more day with my daughter, one more day. And he told me that he knew a doctor at the University of Chicago who was doing some really incredible stuff. He told me that this doctor, who was a friend of his, was doing experimental research, and that the stuff that was happening at the University of Chicago was novel. And he said, don't start it. He said, I will contact you if my friend will be able to speak with you. And then an hour, Dr. Sikorsky, just like he did for this afternoon, Dr. Lukas called us, Dr. Rimas Lukas, and he said that he would be willing to see us in the following Tuesday, but it would be in Chicago. So the four of us got in the car and we drove to Chicago and we met Dr. Lukas. And Dr. Lukas was by our side every step of the way. The last visit that we had with Dr. Lukas was on February 23rd, 2015. And I remember how, I remember that last visit with him. And even then, Dr. Lukas was so generous in the gift of who he was with my husband. When we would get we would visit with a local oncologist here in the Southwest area of Michigan. And they weren't used to seeing some of my husband's progression with his cancer. They were used to seeing many environmental types of cancers, but they weren't really used to seeing and the aggressive form my husband had. And so when we would go to Chicago with the grim news that we would get from our local oncologist, Dr. Lukas always gave us hope. And in the journey, and it was very realistic hope. So if they would see scar tissue on an MRI, my husband had more brain cancer, Dr. Lukas MRI and meet with the tumor board, and they would come back to us and say, it's just scar tissue. The MRI is unremarkable. And for us, whatever Dr. Lukas said or shared was truly Bible, because we got to the point where we would say, hey, you can tell us whatever. We were never disrespectful to the doctors. So we would say to the local doctors, okay, we'll just keep praying about it and we'll just keep on this journey. But in our hearts, we knew that we were not going to accept what the reality of where my husband was until we met with Dr. Lukas. One of the times we went to see Dr. Lukas and was able to do this interview for the CBS News. And we wanted to share that with you before I introduce both Dr. Lukas and Dr. Horbinski. Did you do the sound?
Janet, Janet, we're not hearing the volume.
You had to do it.
Turn it up.
You have to do that and that. And this one, both of them.
Treatment for brain cancer uses a portable device that creates electrical fields to kill cancer cells.
In this original report, CBS 2's Mai Martinez talks to one man who says he's still alive today, thanks in part to that device that sits right on the top of his head.
How have you been?
Oh, wonderful.
For Rick Ledesma and his family, every day is a blessing. In January of last year, he was diagnosed with glioblastoma, an aggressive, usually deadly form of brain cancer. An MRI revealed a baseball-sized tumor. Doctors tried to remove it, but were only able to get 60% of it.
And he couldn't take out the rest of it because it was wrapped around some, I guess, crucial part of the brain.
Rick was told he had 2 to 15 months to live.
It's devastating. You don't think of yourself at that point. You think of your kids.
His wife Janet started looking for treatment options online and found that electrical work known as tumor treating fields showed promise. That led the family to Dr. Rimas Lukas at the University of Chicago Medicine. Dr. Lukas decided a combination of medication and this device marketed as Optune was the best treatment. The device is powered by batteries in a backpack and uses 36 ceramic electrodes attached to the patient's head. The electrodes generate electrical impulses designed to kill dividing cancer cells in the brain without harming healthy cells.
You can have the potential for the cell to be realizing that it's too much damage, and then they become apoptotic or die.
The treatment seems to be working.
Overall, everything looks fantastic radiographically.
Scans show Rick's tumor is still there, but it's not growing.
What does that extra time mean to you?
It means I get to spend one more day with my children. I get to spend one more day with my family.
Rick gives his doctors in Michigan and here in Chicago a lot of credit for his survival, but he also believes God had a hand in guiding him to them and this new treatment. Live in the newsroom, Mai Martinez, CBS 2 News, Rob and Erica.
So that was who my husband was. He just, even at the end, this is who he was. He had hope and he wanted to share hope. So Dr. Lucas Rimas, who was on this journey with us from day one, and we met him at the University of Chicago Medical School, is now at Northwestern University. When he was transferred to Northwestern Memorial Hospital, we went with him. We transferred our records because we wanted to keep the journey and stay on the journey with him. As we continue to go to the almost every week or 2 times a week, and sleep, Christian would drive us. As we continue to go there, Rick had one conviction, and the conviction that he had was that he wanted to advance the research on brain cancer research. And he was very clear and was very vocal about the fact that when he died, he wanted to donate his body for cancer research. And that's when I came in contact with Dr. Horbinski and his team. And that in itself was such an incredible, because the respect and the dignity and the value for life that my husband had has been embraced by Dr. Horbinski and his team. Last fall, I had the privilege of attending a meeting there at one of the hotels in Chicago to honor the gift of the lives of individuals who had passed by GBM. And unfortunately, I had to go to that meeting alone. My son, my daughter couldn't be there, but there were families, probably 15 other families there. And they were going around the circle saying, well, how much time did your relative have? And they were saying 3 months, and some 5 months, and some 8 months, and some a year. They asked how long Rick survived. Rick survived 4 years and a half. In fact, on February 23rd, which is the picture of in the picture in the middle where you see Dr. Lukas hugging Rick, that was the very last picture that Rick and Dr. Lukas took. That was on February 23rd, 2018. And what's important about that picture for me is that at that visit, that was the first time that Dr. Lukas said to us, perhaps the time has come for you as a family to consider hospice. And it was when he said, it was at the point that Dr.
Everyone, if you're not talking, everybody except for Janet should have their Zoom account muted, please.
Yes.
So it was at the point that Dr. Lukas suggested hospice that we knew that we were really coming to the end of our journey. But what's so for us as a family is that was February 23rd. And Rick survived 100 more days on this journey. Stop. One more drink of water. Sorry. both my kids is texting me and telling me to get it together. I enough. Dr. Lukas and Dr. Horbinski for the article that came out, Advancing Cancer Research with Rick as one of the subjects in it. This is what he would have wanted. And both of them published in this article. And if there's anything we can do as a family to help on this journey, we are here for you. Is there anything you want to say?
And I'm here as well, sorry. I just wanted to give a huge shout out to the patients and people that have been suffering with GBM, but mostly the doctors. The doctors, like I said, like my mom said, Dr. Lukas was my first doctor outside of Lakeland that we actually came in contact with as a family. And from that very moment, I knew we were going to be a family unit going through. It wasn't just going to be the 4 of us, it was going to be the 5 of us going through. So it's just a huge testament to what they have done. And I can't speak highly enough about the 2 men that are in this room that were a part of our cancer journey. And I hope that they can bless you guys just as much as they blessed us.
So in closing on my part, this Bible verse has given us a lot of comfort as a family. It comes from Isaiah 57, 1-2. And it reads as follows. Good people pass away. The godly often die before their time, but no one ever seems to care or wonder why. No one seems to understand that God is protecting them from the evil to come. For those who follow godly paths will rest in peace when they die. And we believe without a doubt that my husband is sleeping in Jesus. And we long for the day where Jesus returns and we will be reunited as a family. And we are so thankful for people who are willing to invest in the journey of cancer research, and especially when it comes to brain cancer research. So Dr. Lukas, the time is yours, and then Dr. Horbinski. And Dr. Lukas, you can just unmute your mic, and thank you again for being with us.
Thank you, Janet. I'm gonna share my screen now and let me know if you guys can see this. Visible? Great. Okay. So, first off, I want to thank Janet and all of the Ledesma family, as well as Dr. Murray, for inviting both Dr. Horbinski and I to have this opportunity to speak with you. I think that what I want to highlight is the human interaction or the human aspect of things in addition to the scientific one. What I was going to do is discuss a little bit about the standard treatment for glioblastoma, and then cover some of the research that we have going on, some of the research that actually Rick participated in, or some of those types of concepts. And a lot of my work is focused on the area of immunotherapies, or how do we harness the immune system to fight cancer. So big picture wise, brain tumors are, generally speaking, fairly rare. And so the community oncologists that you had met with, they're not going to see a very large number of patients with brain tumors. When we think about brain tumors, one of the best data sources for us to get a handle on how common they are is the Central Brain Tumor Registry of the US, or the CBTR-US. And when we look within the CBTR-US, we can see that the brain tumors are broken up into a number of different subtypes. One of those big subgroups are infiltrating gliomas, and within infiltrating gliomas, there are glioblastomas. So they're not the most common of all the brain tumors, but as a neuro-oncologist, we're oftentimes involved in their care, and they form the bulk of the clinical activity that we are involved in, as well as much of the research activity. Now, to pull back with regards to how do we treat these brain tumors, as Janet had mentioned in Rick's story, The first step is typically surgical resection, meaning the surgeon cutting out as much tumor as possible. And this is both diagnostic, meaning that it tells us what the problem is, and then it's therapeutic. So it gets rid of a lot of cancer cells. And then this is followed by a regimen of radiation with temozolomide chemotherapy. And our division chief, Roger Stoop here, is the lead author on this study. And what this study was able to prove was that the combination of an alkylating chemotherapy, so a chemotherapy that adds things on to places in DNA in some specific places, including the O6 guanine position, leads to tumor cell death. And then that in turn can lead to an improvement in survival, as well as improvement in what's called progression-free survival, living longer without tumor growing. Now, the problem with temozolomide, as Dr. Murray had alluded to, is that these therapies that are effective don't work indefinitely. So at some point or other, their benefits peter out. This chemotherapy became part of the standard of care in 2005, and it was a number of years until we had additional advances that were demonstrated to improve survival. The real next big advance from my perspective was tumor treating fields, and you saw a video of Rick wearing tumor treating fields. So tumor treating fields are a device which creates electrical fields going one way and then the other way via these 4 arrays that are applied directly to the shaved scalp. And when we take things that have polarity and put them within an electrical field, they move around. There are structures within the tumor cells, in particular something called the mitotic spindle, which is the framework upon which the tumor cells set up their genetic info to make 2 cells, 4, 8, 16, 64, 32, 64, etc. And if you have that mitotic spindle oriented appropriately within an electrical field, that will be disrupted enough in a way that ideally either A, leads to tumor cell no longer dividing, so a cytostatic effect, or B, leads to frank tumor cell death, so something that's cytotoxic. Now, as I mentioned earlier, having the tumor appropriately oriented plays a role, and that's one of the reasons why there are 2 sets of arrays creating 2 electrical fields. Now, one of the drawbacks of this type of therapy is that it doesn't provide excellent coverage further down into the brainstem, and Dr. Horbinski, I think, may allude to this a little bit later in his presentation. And so, but it does provide good coverage to the tumor tissue that's present supratentorially or higher up. We know that the efficacy is related to duration of therapy, cumulatively over the course of a month. So if you treat it for a longer amount of time each day, there's an association with a greater degree of benefit for a specific patient. With regards to the overall duration of therapy, typically as long as this therapy is working, we continue with it. And we oftentimes will do this in conjunction with the traditional cytotoxic chemotherapy, that temozolomide. When we look at the evidence for efficacy, so why do we do this? The rationale is in a phase 3 study, there was demonstration of improvement in overall survival, progression-free survival, and landmark survival. So patients living longer without tumor growing, and more patients being alive at specific time points going out to 5 years. In addition to that, we can see in at least a subset of patients, when the tumor treating fields are used by themselves, that we can see radiographic responses. And that's what we have demonstrated here from what's called the EF11 clinical trial. When we look at tumor here, this area of enhancement that's present around this resection cavity over time may diminish. And this is without the addition of the temozolomide. So we know that there is some biological efficacy, or at least for me, that this type of a radiographic finding speaks to that. Now, unfortunately, the incidence of radiographic responses is fairly low. So the majority of patients have stability of disease if this is being successful, as opposed to frank shrinkage of tumor. Questions about the standard of care before I delve into the research related to immunotherapies? No? Okay. So what I wanted to talk about were immunotherapeutic approaches that our group is interested in evaluating within the context of glioblastoma. And to give the 35,000 foot perspective, so immunotherapy is trying to get the immune system to kill cancer cells. This type of approach has been remarkably successful in some types of cancer. So one of the, I think, biggest wins has been within the context of metastatic melanoma. So metastatic melanoma has a very high mortality rate, and it's a disease in which we've been very unsuccessful in treating until the advent of immunotherapies. And what we're seeing is by manipulating the immune system in the setting of melanoma, we had patients who had sustained responses. So meaning living without tumor growing, and a subset of patients who were cured of what was deemed previously to be an incurable disease. That sparked a tremendous amount of excitement within the field of oncology, and this spread to a number of different tumor subtypes. And one of those subtypes where this has been actively explored has been within the context of glioblastoma. Unfortunately, at this point in time, we do not yet have evidence for efficacy of immunotherapies, but that doesn't mean that it's not worth looking at. And I think for me, there is a perspective that a combinatorial approach, so using more than one thing, may be able to overcome that immune suppressed tumor microenvironment. So I wanted to highlight 3 specific types of approaches that we are looking at. These are not the only approaches being looked at. There are a number of groups, considering other ways to manipulate the immune system with the goal of trying to kill tumor cells. So one of those that I wanted to touch on was PD-1 or PD-L1, which is what's called an immune checkpoint. And so the way that I conceptualize this is we have our immune system, which eagerly wants to fight off all the terrible things within us. It wants to fight off the bacterial infections. It wants to fight off COVID-19. It wants to fight tumor. Within the context of the switches that allow us to move it forward or pause it, one of those important switches is what's called PD-1 or programmed death 1, and it binds to something called PD-L1. And the way you can conceptualize that is a potential break on the immune system. So as the immune system is going everywhere, fighting, if it continues fighting, it will, 1, become completely exhausted and wear us out. And then 2, it may become misdirected and start fighting the wrong thing, causing autoimmune diseases, thyroiditis, pneumonitis, multiple sclerosis, etc. So we have these intrinsic systems to help stop that immune system. And one of those is this PD-1, PD-L1. And so when we pharmacologically block the brake, block that PD-1 or PD-L1 part of the equation, we can have the immune system now, once it's gotten to where it needs to get to, continue fighting what we want it to fight. Another approach is to consider stepping on the accelerator. And so the IL-12 is one example of that. And so there are ways that we can push that immune system forward. And the last approach that I want to touch on is playing with the transmission. So the factors that connect the entire system together, and in this case, play a role in creating that immune suppressed tumor microenvironment. So for my own research, one of the areas that I've had particular interest is playing with the transmission and playing with the brakes. And here I'm highlighting some work that has arisen from Derek Wainwright, one of the basic science researchers in the Department of Neurosurgery at Northwestern University, from his lab and from a number of his postdocs. So within the context of Dr. Wainwright's lab, he studies mouse models, so mice with brain tumor, and intact immune system. And in the laboratory, they conduct clinical trials on the mice, just like we conduct clinical trials in human beings. And what they have been able to demonstrate, and this is what's called a Kaplan-Meier survival curve over here, what we have is the number of mice that are alive over a specific amount of time. And the steeper the line, the shorter the survival for the mice. And then once we have something like this, we have a tail of the curve. So we have mice that continue to be alive and are cured of disease. Within the context of those animal clinical trials, what they have looked at is blocking the brake with that PD-1 antibody. They've looked at playing with the transmission with the IDO inhibitor. They've looked at utilizing radiation to kill tumor cells. Looked at all these things as monotherapies or by themselves, as well as dual therapies. And when used in that fashion, they don't seem to work. They're not adequately effective in these mice with brain tumors. But when you use those things, all three things in combination, we can have mice that survive. And the concept here is that we are killing a lot of cancer cells with the radiation. We're stimulating the immune system with that. We're having an influx of immune cells going in. Those immune cells ideally have had the brakes pulled on them so they can keep going. And we're also dampening the negative feedback loop, that IDO that I had mentioned earlier, that creates a very dampened local immune environment. And so within that context, we're able to take mice and potentially cure them of cancer. If you expose those same mice to the same tumor, 100% of the mice are able to get rid of that tumor. So their immune systems remember what was there before. If you expose those mice to a different tumor, about half of them are able to cure themselves of the tumor, meaning that there is some crossover. So it's not just a single focus on what they've seen before. Now, we've taken this same concept and we've begun to explore this within the context of clinical trials in humans. So in individuals with glioblastoma, and we've probably about 2/3 of the way through the initial clinical trial. For us, we're looking at the safety of this type of an approach, and that's really the primary evaluation in these early phase studies, but we're also interested in trying to get a hint of some efficacy. In addition to that, we're interested in what are called correlative studies. So trying to learn a little bit more than just the basics. One of the correlative studies that we're going to be embarking on in the very near future is advanced PET imaging. So PET scans, featured over here, are a way that we can look at parts of the body. And while the MRI scans, which are featured below, look at the overall architecture of the structures that we're interested in, the PET scans look at the metabolism. Most PET scans look at the metabolism of glucose, sugar. So tumors burn up more sugar, and we can follow that. That type of an evaluation hasn't proven really efficacious within brain tumors. And so we're looking at advanced PET scans, specifically looking at what are called amino acid PET. And in particular, because we're studying this enzyme, IDO, which plays a role in converting tryptophan into a bunch of other downstream products, including some that are very immunosuppressive, we're looking at PET scans that evaluate the tryptophan metabolism. And so that's what is here. This is from an earlier pilot study, and then we'll be moving forward with the bigger study within the context of this clinical trial. But for us as clinical researchers, we want to try to learn as much as possible with each endeavor that we have. And this all obviously takes time and money, but we think that it is well worth it. This is one of the concepts that that we have going forward, and I think this serves as a nice example of the common bench to bedside refrain that you guys oftentimes hear. So taking concepts from the bench, from the laboratory, and then bringing it to the bedside, and then examples of bringing it back again as well. The other therapeutic approach that I want to discuss that we were investigating as well within the immunotherapeutic realm is stepping on the accelerator. And this is actually a trial that Rick had screened for but was not able to actually participate in. This is a concept that I think is very exciting. And so what happens here is patients undergo a surgical resection, and during the surgery, the neurosurgeon injects a virus that has been engineered to infect the tumor cells. And when the virus infects those tumor cells, it brings a gene into those tumor cells. So the virus is merely a vehicle to get something to where you want it to get. The gene is what plays the role from a therapeutic perspective. And then once that gene is in place, we as the physicians can prescribe a medication that turns the gene on. It flips the switch to allow the tumor cell to make whatever the gene encodes. And in this case, it encodes something called IL-12. IL-12 is a pro-inflammatory cytokine. So it's the stepping on the accelerator. And it's stepping on the accelerator extremely aggressively. And if you step on the accelerator extremely aggressively throughout the entire body, the body can't handle it. You get what's called cytokine storm, which you might have heard of within the context of the COVID pandemic. And so here the idea is that you can step on it where you need to step on it intracranially, and that you can step on it in a controlled fashion. And you can step on the accelerator. If you start to see problems, you can let go of the accelerator. You can step back on it if you want. And the idea here is that you get the immune system riled up to start killing the tumor cells. And then in addition to that, we do add something, this again, PD-1 antibody. Again, now we're removing the brake on this system. So we're pressing the accelerator and removing the brake. And then what we have here is some imaging. This is from a patient of mine where the patient was treated. They had this large abnormality. And then I actually have a more updated scan, just saw them probably about a month or so ago, and it looks just like this. So we have this sort of burnt out, dead, empty area without any viable tumor. So it's situations like that which make us excited about the results that we're seeing. And that is, I think, the brief whirlwind tour of what we do with regards to the standard treatments as well as some investigational approaches. And I'll pass the baton over to Dr. Horbinski while acknowledging all of my colleagues, because none of this is a single person effort. As you guys are already aware, this is a situation where there are numerous contributors. And in addition to the physicians and the scientists involved, patients and their families play a big role in all of this. Go ahead, Craig.
All right, here we go. Can everybody see that? All right, very good. Now, there is a term, if you haven't heard it already, if you go into the biomedical world, you're going to hear it about 10,000 times. It's called bench to bedside. That's the idea that basic science laboratory discoveries eventually translate themselves into better patient care in the form of better treatment, etc. But in reality, there's a synergy. It's a two-way street, because patient-based observations can also greatly inform new therapeutic research in the laboratory. So it's not just a one-directional flow. Now, as far as gliomas go, just to take a step back, it's actually the most common tumor that arises in the brain itself in adults. Now, the most common cancer in the brain is actually metastatic cancer, typically from lung or breast or melanoma, something like that. But as far as cancers that arise in the brain itself, gliomas are the most common. In the United States, they strike about 17,000 new cases per year in the United States, just alone. Globally, it's actually the worst cancer in terms of overall life years lost, because they can hit younger people. There's really no modifiable risk factors that you can control. I mean, it's not like smoking or diet or anything has any link with brain cancer. And unlike, for example, colorectal cancer, you can screen for that. Breast cancer, you can screen for it. Patients, especially these days, the survival of those kinds of cancers is really improving. Glioma, it really hasn't. It's only a few months better, a couple months better than it was even 30 years ago. And that alone suggests that our patients are trying to tell us something, that despite years of research and entire careers devoted towards better therapeutics for brain cancer, it's not working. I mean, notwithstanding, of course, what Dr. Lukas just presented, still as a field, we are not where we want to be. So that, in a sense, really warranted, I think, a revisiting of the tumor itself, really looking again at what this disease is all about. Now, I should warn you, you've already seen it, but these are pictures. You can easily find these pictures online. These are pictures of end-stage glioblastomas at autopsy. There will be additional pictures, hopefully not too gory or triggering or anything, but just FYI, that's coming. Because I'm a neuropathologist, this is what we do. Now, this is the common perception of glioblastomas at the end of life. Is you get these large necrotic masses, these hideous masses that are squishing the rest of the brain. And of course, since the brain's in the skull, there's no place for the brain to go. So it pops down from the top of the cranium into the lower part of the cranium, which is called herniation. That leads to compression of the vital brain stem. That's the section, part of the brain, the very basic, ancient part of your brain that controls your breathing, your heart rate, all those sorts of things. And when that gets damaged, that's it. It's lights out. So that's the assumption that we've had that that's what these glioblastomas look like at the very end, and then that's why patients are dying of cancer. And in fact, even just 10 years ago, a study was done in Denmark focusing on the end-of-life symptoms in these high-grade glioma patients like glioblastoma. And what they found was that the top symptoms that patients had at the end of life were things like decreased consciousness, difficulty chewing and swallowing, progressive movement deficits, all which they were attributing to the brainstem dysfunction that they assumed was happening in these patients. In fact, they presumed cause of death was brain herniation due to the tumor progression. However, in this study, which was otherwise excellent, the one weakness, it didn't have any pathological correlation that there really was herniation going on. They assumed it was going on, but they had never really proven it pathologically. And that's because historically, at least in the last 20, 30 years, there haven't been a whole lot of autopsy studies on glioblastoma patients, because the assumption is, okay, we know why these patients are dying. We don't need an autopsy to prove it. Well, here at the Northwestern Nervous System Tumor Bank, we've been around, we're a relatively newer bank compared to some other tumor banks. We only started in 2014, but we've been very active since then. We've collected over 2,000 tumors of all different kinds with matched blood, supporting a ton of active and completed research projects from a lot of investigators, both at Northwestern and even across in other countries, some of which were included in what Dr. Lukas was mentioning. We initiated this rapid autopsy program in late 2015 with the goal of obtaining end-stage post-therapy glioblastoma tissue as a way of studying mechanisms of therapy resistance, which Dr. Murray and company were talking about earlier, as concerns specifically one of the chemotherapies that's being used, the temozolomide. Well, what we found was something very different. So this is a picture actually of not of nobody you would know, or it's not like Enrique's autopsy, but this was a different person, older, middle-aged man, left temporal IDH wild-type glioblastoma. So this was a very specific subtype, very aggressive subtype of glioblastoma, but he beat the odds, survived a little over 3 years. It was in his left temporal lobe. Now, if you know what the neuroanatomy is all about, you know what the left temporal lobe, where that's located. As soon as part of the autopsy, we separated the posterior fossa structures, which include the brainstem and cerebellum. We separated them from the cerebrum, the supratentorial compartment. And as soon as we did that, when we looked at the midbrain here on the left, the cerebral peduncle in the left midbrain that's on the same side as that left temporal lobe tumor was all swollen compared to the right side. So we're looking up underneath. This is the left and this is the right. Likewise, the pons that was connected to the midbrain, the left pons was also swollen compared to the right side. And when we later fixed the brain in formalin and then coronally sectioned it, we saw, this was really surprising. Remember what those pictures look like of end-stage glioblastomas at autopsy that I showed you earlier in the presentation? Remember how big those tumors are, how necrotic they were? And how they were causing brain compression and herniation. Well, here, this is what the tumor looked like at the very end. That's it. That's the left temporal lobe tumor. This tiny little thing right here. It just didn't look that bad. To the naked eye, it didn't look that bad. There's a little bit of streaky, yellowish discoloration. That's it. No mass effect, no midline shift, no herniation. I've seen plenty of patients with advanced dementia or traumatic brain injury whose brains looked a lot worse than this and survived for decades. So this was really surprising. The pons on that same side, however, was certainly swollen. Now, here you can see under the microscope, this is what a neuron looks like in the pons under the microscope. This would be a neuron that helps control the major cranial nerves. I don't know how much neuroanatomy you guys have had, but the cranial nerves are essential for life. That's how you breathe, you chew, you swallow, heart rate, the whole bit. These neurons are absolutely critical. And most of the other little irregular wrinkle things that you see crawling through there, that's the cancer. This is the cancer that started way up in the left temporal lobe and has crawled down into the brainstem to overrun the pons. Now, on the right side here, this is a special stain we use called Luxol-Fast blue. That stains the white matter. It stains the white matter blue. That's the axons, the kind of the wires that connect the brain. That's what normal Luxol-Fast blue is supposed to look like. Lots and lots of very densely, nicely myelinated white matter axons. This is what that pons looked like. It was massive loss of those wires. So that indicates a pons that is no longer functional. The brainstem is not functioning like it's supposed to, not anywhere close. Different case, totally different case. Younger fellow, tragic story. He had a 6-year history of a different kind of cancer, an anaplastic astrocytoma, that eventually progressed to a glioblastoma. Here was his autopsy, right frontal tumor. This is where the tumor started. The tumor had been surgically resected, very good resection. All that was left up there was an empty cystic space. And what you see surrounding it is just this little rubbery gliotic scar, but that's it. Again, there's no mass effect, no midline shift, no herniation. It's very unclear why this is happening. I mean, you look at that brain and just, I've done autopsies on thousands of patients, and this brain does not look that bad. I mean, a patient like that you would expect to survive, no problem, except you look a little more carefully, higher magnification, you see these little streaks of yellowish. That's all tumor. The tumor started up here and crawled down these white matter tracts. It got into the ipsilateral or same side right temporal lobe, and also progressing further down into the posterior fossa. You don't see it here because it was removed, but that's the posterior fossa. That's where the brainstem would be. And it's crawling right towards that brainstem like a laser is crawling towards it. And sure enough, when we look in the midbrain on the same side as that original tumor and the pons, those same necrotic yellowish streaks under the microscope, the same thing that the other case showed. You have a few neurons here, here, and here, and here, but mostly they're completely surrounded by cancer. So neurons that are completely surrounded by cancer cannot work. They're not going to fire normally. Their electrical signals are going to be disrupted. Even if the neuron itself is not being destroyed, it doesn't matter because it's like bugs crawling through a computer. There's a short circuiting that's going on. And it happened. This was a whole slide scan of the pons. So you're looking about 2 to 3 centimeters across in diameter. That's the scale we're looking at. And the right side here is completely replaced by tumor. It's non-functional. This is what a normal pons should look like at medium magnification. This is about 200 times about 100 times magnification. That's what the patient's pons look like, completely overrun by tumor. Over 90% of the cells that are in this field are cancer cells. The pons can't function. If the pons can't function, that's it. Basically, the patient goes to sleep and that's it. So what was interesting is then we decided this was really a surprise. We were not expecting to see this extent of brainstem involvement. We were expecting to see all these brain tumor patients dying of herniation and mass effect from the tumor. So we went back to the original studies that were done a long time ago when autopsies were still pretty common. These are 3 of the classic brain cancer studies, autopsy studies that were done like 30, 40 plus years ago. And the long story short, when we compared our cohort with those older studies, we found that the mass effect from the tumor is less common in our current cases, and typically it was very mild mass effect. It would not have been enough to kill a patient. Whereas it was quite common in the old days. But instead, not in herniation likewise was very uncommon, whereas now it is, but in the old days that was typical. I mean, half the patients clearly died of brain herniation from the tumor. Instead, in the old days, only about 1 in 5 cases showed any kind of brainstem extension by the tumor. However, in our cohort, and this is held up in subsequent, we have over 40 cases now, over 2/3 of our patients are showing very, very heavy brainstem invasion, and including Enrique Ledesma's case. He was one of our heaviest involved because he survived the longest. So the people who are surviving the longest are the ones most likely to have this brainstem extension because they live longer. The tumor had more time to crawl down there. But once it gets down into the brainstem, that's pretty much it. You know, there's nothing else we can do, because once the brainstem short circuits, that's the end of life. And the thing is, especially now with this connectome, I don't know if you've heard about the connectome. It's a brilliant series of detailed radiologic studies indicating just how interconnected each part of the brain is to each other. Every part of the brain talks to each other. There's wires connecting everywhere. But what that means is, for a cancer like glioblastoma, is it can crawl from any part of the brain to any other part of the brain, especially the brainstem, because every part of the cerebrum is directly connected to the brainstem, that vital structure down here. It's like a highway. The tumor cells, we can see them literally crawling along those axons, those white matter tracks, just like a highway, like ants through a computer. No other cancer does this, by the way. This is the only kind of cancer that spreads in this fashion. The problem is that over 98% of the preclinical models that we use to inform new clinical trials are based, for example, on taking these human tumors and then implanting them into a mouse brain like we have here. This is the tumor, human tumor, in a mouse brain. And the thing is, in contrast to what I just showed you, this tumor, this human tumor, yeah, it's growing in the mouse's brain, but it's really not spreading into the mouse's brain tissue in the same fashion that human brain tumor spreads into the human brain. Instead, when these tumors grow and they kill mice, when they eventually kill mice, they're killing by that good old-fashioned mass effect that we used to see decades ago in humans before the advent of better neurosurgical resection, better radiation, more targeted radiation, and temozolomide. So in other words, the preclinical models and the new therapeutics that we're testing, they look great in these models of mouse tumors. The mice are not dying of the same mechanism of disease that patients are dying of. It's the same tumor, but it's not the same mechanism of disease because the tumor spreads different. And that goes a long way towards explaining why preclinical models can look terrific. You can cure a cancer in a mouse brain, and then you try the same therapeutic in a human brain, and it doesn't quite work because you're not reaching exactly where the tumor is spreading. So, and we don't have to go into too many of the details, but this does go a long ways towards explaining why a lot of the preclinical data that we've been so hopeful for usually falls flat in these clinical trials. And it actually is already starting to change people's thinking because, for example, the preclinical models we're trying to develop better preclinical models that actually do mimic the type of spread. Clinical trials, like what Dr. Lukas was talking about. You know, instead of waiting for the tumor to recur at the original site, be more aggressive. If you have a promising therapeutic, start it sooner. And focus on therapeutics that are really going to spread throughout the entire brain and not just treat the original tumor site. Because treating just the original tumor site is unlikely to have much of an effect on patient outcomes unless you can deal with this brainstem extension. So what was really, and actually this was just published earlier this year, the advanced access was in late last year, but it officially came out in print in April of 2020. And it actually made the cover. So that just underscores the interest in the general community about this. In fact, the timing of this particular session is perfect because just a month ago, a Norwegian group published a letter in response to the paper that we issued saying, first of all, they love the paper, which is always nice to hear. But they have come up with a model of a human brain tumor that actually does spread. It's a little hard to show here, but it really does spread from the top of the head in the cerebrum all the way into the brainstem. So they've got a model that they think finally does recapitulate the pattern of spread that we're seeing in humans. And that's great because it means the models like this, hopefully, because the better your model, the more reliable your results are, and the more likely that anything you find is going to have an effect on patients. So really grateful I have a tremendous group of people who've been helping me with this. Our Nervous System Tumor Bank is staffed by some tremendous people. The study that I'm talking about here in particular was headed up by a medical scientist training program student. who was truly outstanding, Michael Drum. Lots of people to thank, just like Rimas. It takes a team, and we're very, very grateful for everybody. A lot of great support over the years. The Lou and Jean Malnati Brain Tumor Institute is an outstanding entity. If you're ever in Chicago, the Malnatis, they own a pizzeria chain. You have a Chicago deep dish pizza. Go to the Malnati. My own son thinks that they have the best pizza, and they don't even know. I didn't even tell him that they support my research. They're very generous with the support, so it's an unbiased opinion on his part. That's all I have. Any questions for any of us?
So I could, are there any questions?
Some really good ones in the chat room, Dr. Murray.
Okay.
Do you want me to read them or you want to read them?
Sure, you could start with one and then I could do the next and stuff.
Sure. I'm going to go back up because there was a question about what causes, it was right after Dr. Lucas's presentation, and the question was, we have any background on what causes GBM?
Yeah, so that's an excellent question. That's, from my perspective, that's the multi-billion-dollar question, right? And we don't have the answer to that. As Dr. Horbinski alluded to, there's no obvious driver from a environmental risk factor perspective. So smoking or drinking or head trauma are not associated with that. We do know that ionizing radiation increases your risk. So if you, as a pediatric patient, have radiation to the head, there's a risk that a number of years down the line you may develop that. And we know that there are certain cancer predisposition syndromes which also increase your risk. Interestingly, having active immune system within the context, say, of allergies decreases your risk of developing GBM. From my perspective, the way that I would sort of view it is that we have aberrancies within cells, tumor precursor cell, and I'll let Craig correct me if I'm wrong or add his own 2 cents in it, but we have tumor precursor cells that have some type of genetic abnormality or epigenetic abnormality, and they're within the appropriate environment. And I think that those are sort of 2 parallel areas that are clearly integrated with regards to research for us to better understand where these things come from, and then ideally work our way backwards and figure out how we can treat these things once they do arise. Greg, do you have comments on that?
Yeah, so it turns out that as far as risk factors for gliomas go, the older you get, the greater your risk, at least beyond a certain point, and then the risk starts to drop a bit. Caucasian ethnicity, male gender. Obviously, there's not a whole lot you can do about any of those things unless you want to die young. Also, prior exposure to ionizing radiation. So one of the really tragic cases, like I still see people who survived the Chernobyl disaster in 1986, and they'll still be coming in with brand new brain tumors that are clearly caused by the radiation all those years ago. So those are the major risk factors. However, there are a relative handful of inherited diseases like Lee-Fromenai, Lynch syndrome, others, that are clearly, these are the genetic mutations that are inherited and they're present in the entire patient that clearly are causing brain cancers. Most patients, however, appear to get these brain cancers just by bad luck. It's just sporadic. Although that said, we are finding out with more and more advanced epidemiologic studies that, it's never so much, it's usually not as straightforward as, oh, one little mutation and you're going to get a cancer. It's not that clean cut. It's like a little variant here slightly increases your risk. Another variant here might slightly increase your risk. A third variant might decrease your risk. And it's the interaction of all these variants changes your odds at the roulette wheel. And that's where we're at. And I know, in fact, we've been sending a lot of the biobank tissues that we collect are sent to large studies like San Francisco and Duke and Mayo Clinic. They're doing these huge epidemiologic studies trying to determine what kind of inherited risk factors, multifactorial risk factors that are present in brain cancer. Very, very sophisticated bioinformatics analysis, very complicated stuff.
So we have another question. Is hemispherectomy, I can't pronounce that word.
Hemispherectomy, yeah.
Yes. Is that a possible solution to stop the tumor's march to the brain stem?
So the answer is no. There were earlier studies done, and these were in really the pre-imaging era where hemispherectomies were performed. And this dates back to like the 1950s or so. And they were not successful in curing patients of disease. You can make the argument that it's a different time period now, but I'd still harbor that same worry. The other issue with respect to hemispherectomy is that it creates a tremendous number of deficits, right, that did not exist. And we have pretty clear evidence that if the surgeon creates new deficits, that's associated with a truncated survival. And so in turn, we don't do it. But it's a good idea, right? Or it's a good point to sort of bring up, like, how do we stop this thing from getting where it wants to get to?
Mm-hmm. Do you think chimeric antigen receptor T cell therapy possibly can impact the treatment of brain cancer?
Yeah, so what that is sometimes called CAR T cells for short. And what these are T cells, so immune cells, that are taken out. They're engineered to go after something. And they're engineered to go after a specific abnormality. And they've demonstrated success in what's called hematologic malignancies or blood cancers. And in blood cancers, you have an extremely clonal process. So you have your bad cell or bad cells, and they all replicate themselves, ad infinitum. It just kind of keeps making more and more of it, and they're fairly similar to one another. Now, the problem with glioblastoma, as the old name, the Multiforme, alludes to, is that there are multiple forms, right? It's not just one cell here that's the exact same as its sister cell here and the cousin cell over here within the brain. These things have a wide range of abnormalities. And the problem with CAR T cell therapy is that at this point in time, we can only engineer these cells to go after one, maybe two things. And even if we improve, the likelihood that you can kind of engineer a T cell to go after everything that you wanted to is going to be low. And so the problem is, if you kill off all of this tumor cell type, but you've left behind all of this and all of this, you're not going to be successful. And that's been demonstrated in other immunotherapeutic approaches that have targeted just one specific epitope or one specific abnormality. So I would worry that the CAR T cells could have a similar pattern. And that's not to downplay that, the novelness of the idea, or that it couldn't potentially be beneficial as part of a combinatorial regimen, but by itself, I don't think it's going to pan out. That's my little.
Yeah, and to echo that, so we think of it as one discrete tumor. If you think of it as a solid tumor, and the old idea of cancer is this clonal proliferation of otherwise identical tumor cells, that actually isn't quite true. Even in each of these cancers, each of these brain cancers, if you really sequence different parts of the tumor, on average, we're finding that they are genetically distinct. So you have like 6 or more genetically distinct subclones of tumor within a given tumor. And that goes a long way towards explaining why a lot of these molecularly targeted therapies haven't worked out too well, because at most you're only treating a fraction of the tumor, because the rest of the tumor just doesn't have what you're targeting. In fact, that's why one of the follow-up studies that we're doing with this cohort is we're sequencing the original untreated tumor. We're sequencing the tumor after therapy at death that stayed near the original tumor site, and in parallel, sequencing the tumor that made it all the way down into the brainstem to see how distinct that brainstem tumor is from what stayed put near the original tumor. And hopefully, with a little luck, we might find some insights as to why some parts of the tumor like to spread so far into sensitive structures like the brainstem, and other parts of the tumor stay put and they're content to remain where they grew. Because if we can transform this into a local disease that doesn't spread in that fashion, now all of a sudden it's a totally different ball of wax. Now you're really focusing, now you're dealing with a locally recurrent tumor that can just be re-resected and managed locally. Now that's would be our dream.
Okay, so another question here is the immunotherapy developed from the brain immune system, or is it the general immune system which then goes to the brain?
Yeah, so that's a messy answer. In general, it's the immune system from outside of the nervous system that we really want to be able to harness in a positive fashion. Now, that's complicated because we already have existing immune cells within the nervous system, and a lot of those, at least within the context of glioblastoma, play a very what's called immunosuppressive role. So they help dampen things down further. So that's one of the problems that we have to be able to figure out how to overcome. So in really sort of broad strokes, the idea is we want to change that dampening signal there, and we want to be able to draw in a bunch of things from elsewhere to our area of interest, to our target organ up here. Now it's further complicated by the peripheral immune system is sequestered away. There's a guy, Peter Fecci from Duke, who's demonstrated this really nicely, that the tumor presumably is signaling to the immune system in some fashion to say, keep these immune cells, which should be fighting all the bad stuff, hidden away in your bone marrow and your spleen. And in turn, they're not doing what we want them to do up here. At the same time, we're not necessarily seeing a disproportionate amount of infections in our patients either. So somehow it's still, this immune system peripherally, even if it's sequestered, it must still somehow be able to do what it needs to, at least intermittently, within the setting of systemic infections.
I just ask a follow-up on that, then. Are these new immunomodulatory agents, would they be useful in glio, you think?
Yeah, so there's a range of immunomodulatory therapy. So one of them that I had mentioned is the PD-1, PD-L1, and we're using that. We're using it, I think, not as the primary driver for an effect, but as an adjunct. So I don't think that it's going to pan out by itself, but like you can use it, you know, if you have therapy A and maybe now you want to pull the brakes off the immune system, you can also pull the brakes off and you can probably do it pretty safely. There's other immunomodulatory ones like that IDO inhibition, which we think can be, you know, in a perfect scenario, it's you know, at least somewhat of an Achilles heel. Whether it will be or not, who knows? That's something that we need to explore. And there's a number of other switches that we can flip on and off. The problem for us is nobody knows what the best combination of on and off switches is for success.
Yeah, and actually, to follow up on that, so part of the problem is that the brain itself, under normal circumstances, does not tolerate a lot of inflammation.
Yeah.
And there's a number of mechanisms in the brain under normal circumstances to dampen inflammation for good reason.
Yeah.
I mean, think about it. Let's say you hit your hand with a hammer and it starts to swell up. Okay, that's aggravating, but it'll eventually shrink. If your brain starts to swell, that's it. You're done. You know, there's nowhere for it to go. So all those inflammatory measures that the rest of the body can be harnessed to take care of bugs and etc. Brain can't tolerate that. So that's what we're really up against. Is when we have all these tremendous immunotherapies, some of which are working brilliantly in cancers elsewhere in the body. You try it for brain cancer and it just doesn't work because the brain itself just dials it down. It won't allow inflammation. So what we're trying to figure out is the secret sauce to get the immune system to attack that infiltrated tumor without destroying normal brain, without causing some god-awful multiple sclerosis like demyelinating disease or something, and without causing the brain to swell so much that the patient dies of the inflammation. It's very, very tricky, but I really think, especially in light of the study that I just showed you guys, recognizing just how extensive the tumor spread is. And by the way, this is spread beyond what you can see radiologically. You can't see this very well radiologically. It's like the silent killer, so to speak. If the immune system, if we can figure out how to get the immune system to attack that tumor, that's our best bet of really stopping this from happening. Because what else other than the immune system is going to be able to sniff out individual tumor cells wherever they are in the central nervous system? That's what we need.
Okay.
Dr. Horbinski, when I attended the family meeting back in the fall, I was extremely fascinated by the research that you shared in terms of how long the glioblastoma can be in your body before it actually manifests itself. Would you feel comfortable sharing that?
Oh, sure. So based on, and this is actually based on some really, again, sophisticated bioinformatics analysis when you take the tumor and you figure out how many mutations are in that tumor's DNA. and you assume a certain baseline rate of tumor, of new mutations. So, this is all very, very, very complex genomically. It turns out that a lot of cancers, not just brain cancer, but a lot of cancers probably started up to 10 years or even longer before they manifested clinically. So it could start as just one little renewing cell in the brain or elsewhere in the body that acquires one mutation. One mutation by itself is not going to get you a cancer, really under any circumstance. But that cell is sitting there with that funky little mutation, and it could last for years. Then when it divides again, oops, another mutation hits and another gene that you don't want mutated. Well, now you're still, but it's still not quite a cancer yet. Now it's maybe just a cluster of cells that are sitting there kind of on a knife's edge. And then you hit that third mutation and it becomes a numbers game. You hit that third mutation and boom, all of a sudden there you go. And that can take years to develop. In fact, some of the cancers that I even see in 20 to 30-year-olds probably originated, the original lesion, the genetic lesion that started the ball rolling probably happened in utero, believe it or not. That's what we're starting to see. Wow. And it goes, it's a little unnerving if you think about it, because it means God knows what's growing in any of us, right? I mean, who knows? Especially when you consider how big these tumors can get. It never ceases to amaze me, Rimas, that the cases that we'll see where, the patient had just like a week's or 2 weeks worth of headaches and then comes in for a head scan, and they have this 4-centimeter tumor with all this edema. And you're like, how is it that you didn't have symptoms, a year ago?
Yeah.
It's incredible.
It's fascinating. And when I teach our trainees, I talk to them about how if we had that same type of an injury with a stroke, this person would be comatose in the ICU, right? Yep. And then yet they come in with a tumor, they look pretty good. Again, like you said, it's a week worth of headaches or some other thing.
Exactly. And in our case, my husband never had seizures. My husband never had anything going on other than this headache that he would shake off and then it would go away. He was really functional until those 2 months. The next question is and we only have a few more questions. We're trying to really respect your time. So it's just a couple more questions, but can the tumor treating fields be applied to other parts of the body where cancer can be developed?
Yes. So that's, I think, an exciting proof of principle. And in other parts of the body, in some ways, from my perspective, it's a more attractive therapy because, I could be sitting here giving this presentation or answering these questions and have the leads underneath my shirt and nobody would notice, as opposed to having them on my scalp where it becomes much more evident. So the tumor treating fields recently received, I think sometime 2019, probably like the summer of 2019, received FDA approval for mesothelioma, a rare type of a lung cancer that arises in the coverings of the lungs. They're also being investigated within the context of pancreatic cancer, in gynecologic malignancies, in what's called brain metastases, so spread of lung cancer to the brain specifically. In those arenas, it's not clear whether it will be beneficial yet or not. Those results are still pending, but it has demonstrated efficacy in the mesothelioma, the subtype of lung cancer. Okay. It's interesting. The frequency of the fields is different for the tumor cell size that you're actually treating. So you need to change it up.
Okay. So we have a two-part question from our girl, Ariana. What residual effects or worsening symptoms are you seeing neurologically when the tumors aren't progressing? That's part one. Part two, is there research or treatment of neurological defects resulting from the aggressive treatment, such as surgery or immunotherapy?
Sure. So I think the first one I'll address, and it's, the way I think about symptoms, I divide them into two camps, localizable and non-localizable. So localizable is just merely based on the neuroanatomy. You put the lesion here and it causes a weakness on the opposite side of the body. You put the lesion somewhere else and it makes it so somebody can't breathe, right? And then we have our non-localizable symptoms, which are just due to increased intracranial pressure. So as Dr. Horbinski was mentioning earlier, once you bring the pressure up in the system, in this case, but you're adding tumor cells into this fixed box of the skull where there's no room, pressure goes up and people get headaches, nausea, vomiting. They get double vision because you're compressing some of those cranial nerves that move the eyes and they become more somnolent. With regards to the toxicities of the treatment, so the short answer is yes and no. The no part is that the bulk of the energy that we spend in brain tumor research is on curing the disease. That's the thing that everybody's chasing after, you know, and for good reason. And so in turn, these other sort of more tangential aspects don't have the same amount of time, effort, and money invested in them. Now, the yes part is within the context of every single clinical trial, we have safety evaluations as an integral component. And our earliest phase studies, our phase 1 studies, are designed to answer the question of, is this safe to give to humans, right? And then even as we move forward to these other levels of study, the phase 2 and the phase 3 study, where we're looking for efficacy, we still care about that safety profile. And if something is too toxic, then it's too toxic. And then we need to figure out another way to deal with it. We either deal with those toxicities in some sort of better manner, or we scrap it and we move to something else. But those are good points to consider.
Yeah, and it's especially relevant for pediatrics, you know, because a lot of the pediatric tumors, they can be lower grade tumors that maybe you treat surgically and maybe with some local radiation. But the longer term, and so that might be considered as a success because the patient survives. However, when you look at their quality of life and their IQ points in particular, even like, let's say they get irradiated when the brain gets irradiated when they're 10 years old. If you keep following them throughout their life, they're going to keep losing IQ points, even though they are not getting any more radiation. So they're becoming more and more aware now that we have longer term outcome studies, just how deleterious that radiation can be. So toward that end, there's also a lot of interest in trying to administer radiosensitizing drugs, the kind of therapeutics that can get into the tumor. Maybe they don't kill the tumor directly, but they make the tumor a lot more sensitive to radiation so that you can get away with giving less radiation. You know, especially for these so-called, that's why I don't even like calling anything in the brain benign. You know, people say, is it a benign brain tumor versus malignant? There's no such thing as benign in the brain, because even a so-called benign tumor that doesn't kill you can ruin your life. You know, if it's in the wrong spot or anything. So instead I use the terms low grade versus high grade. That's what we use. And right now we've got a project I didn't show you today. Really exciting stuff. Repurposing old anti-cancer drugs against another kind of brain tumor called meningioma. And our data so far really do suggest that if you take some of these old, really cheap drugs now, they're cheap because they've been around a long time, so the patent expired, and you treat meningiomas with these in combination with radiation, you wipe the tumor out. And so we're going ahead full force, and Rimas is part of the project. And yeah, so these are the sorts of things we're working on. You're trying to hopefully move the field forward.
Okay.
Of course, a fascinating presentation would elicit the question that's coming next. One of the students would like to know, do you have any research opportunities for undergraduate students interested in any of your research? If so, how would they engage in that?
Yeah, so I can take it first. So it's tough for undergraduate students, and I think for us it's tough in particular because we do, you know, I do exclusively human-based research, and because of that, there are a number of privacy issues that, you know, make it a little bit more complicated to be able to kind of fit into the system. And then even within that context, it just takes a long time. You know, the IL-12 gene therapy study, the first paper we just published just this year or the end of last year, that's, you know, 5 years of work, right? And that's just the first phase 1 study that's coming out. The IDO stuff, you know, I've been working on now for 3 years, and we don't have a single paper out for, you know, from the definitive, you know, phase 1 study yet. It's going to be at least another 1-2 years before we get that paper out. So it's not a good, the type of time scales that we work on are not great for students, because a student needs to be able to get that publication out that says, hey, you know, I was able to do something. And so the human-based clinical trials research is, I typically dissuade students from doing it, even though I think it's important and I enjoy doing it. It's just, it's not going to give them that sort of next step that they need, at least from my
Now, in
perspective.
contrast, a lot of the laboratory work that I do does tend to turn around maybe a little faster, but we only have so much room in the lab. You know, you can't physically accommodate everybody who would like to rotate. And you know, it does present a burden on my current lab staff and my postdoctoral fellows and graduate students. You know, they're trying to get their own work done. You know, to be constantly training new people, you know, there's a certain time commitment there. That said, you know, if somebody is interested, they can contact me separately. And if I can't accommodate you, then maybe I can, because we have a big brain tumor group. It's probably the biggest brain tumor research group in the country. And we may be able to hook them up with another investigator who's got a project that's going to turn around quickly, maybe some space to accommodate them.
And I promise the students, just based on my own experience, that when these articles do come out, doctors that are engaged in the study and are familiar with, do share those articles with you. And then I do my investigating to weed out and figure out who our person is in our family, client 1, client 2, and we usually get it right on the money. And it's fascinating to read these studies. So thank you for sharing those. And as they come to me, Dr. Murray, I will share them with you and Dr. Smith so that you will be able to have them as well, because it is fascinating research.
Yeah. So as a follow-up to that too, is there a possibility for collaboration where if some of our students make some of these novel chemotherapeutic compounds, and we do our initial studies here and find things that are promising, would it be possible to collaborate with your group or some other group to do further studies that we, for various reasons, can't do here in our labs?
Yeah, sure. I can do that because I have a pretty good pipeline. We have a big infrastructure for doing these tumor-based in vivo models in mouse subjects, and we're doing them all the time.
Okay.
I've got multiple therapeutics I'm testing as we speak, so it's really not that onerous to add a new therapeutic to our IACUC approved list.
Okay.
And for us, we're always looking for clinical trial drugs, and novel drugs are exciting for us. They obviously have to go through the preclinical studies first. So we need to be convinced in the animal model that this is promising before we would embark on, considering giving it to a human being.
Oh, yes, absolutely. Yes, yes. Okay. Well, Janet, what do you think?
There's one last question from Dr. Smith.
Okay.
And that question says, are you seeing any differential expression of enzymes and atoms in the tumor versus the cells in the ponds?
A good question. That's part of our follow-up study, actually, that we're doing as we speak, really trying to characterize in greater detail the kind of tumor spread. What are the tumor cells like in the ponds versus the original site? And we'll see. The answer is I don't know yet. That's why, there's an old saying, if we knew what we were doing, it wouldn't be research.
Exactly.
But we are working on that as we speak.
I guess that goes across all fields, huh, Dr. Again, Dr. Horbinski and Dr. Lukas, personally, I want to thank you for the gift of your time this afternoon and for walking this journey with our family. Dr. Murray, the time is yours.
And thank you to Dr. Ledesma for making this connection with us. Thank you, Dr. Lukas and Dr. Horbinski, for immediately jumping in and saying that you would be willing to help and talk with our students. Thank our students for being here as well, and hopefully have gotten lots of inspiration. Maybe some of them have other questions and we might be hearing from them later on, but we thank you.
Well, sure, and you're welcome to contact any of us separately too. That's fine. We answer questions like that all the time. I want in particular to thank you guys for this opportunity, and thank the Ledesma family and all the families who have been so courageous and donating. I mean, that's a big deal. you know, and that takes a lot of intestinal fortitude to
yes.
have that. I mean, you know, I can't even imagine going through that myself personally.
Right.
But we're so grateful because it really is making a difference. Well, you just saw that follow-up letter that somebody wrote from Norway. Scientists in Norway read the paper, and it's getting a lot of attention. And so I think, you know, these studies really do matter. They really do reshape the field. It takes a long time, you know, but it does. And that's what science is all about, is putting these building blocks in. You know, no one person is going to figure everything out, but everybody works together. We all share what we found. And as time goes on, the corpus of literature and knowledge grows that hopefully sooner or later, I want at the end of my life to look at, or at the end of my career at least, to look at a brain cancer under the microscope and tell my trainees, you know, this used to be a death sentence.
Right, right.
Now we can do something about this. Now it's just annoying.
Right.
Now, that's what we're looking for.
Yeah.
And I can't say enough about Rimas Lukas and all the other neuro-oncologists and neurosurgeons here at Northwestern. This probably is, in my opinion, I'm not unbiased, but I think it's probably the best brain tumor program in the country, maybe the world. I mean,
yes.
The caliber of the people that are here and the compassion that they have, as well as the technical competence, there aren't too many places that can offer that kind of combination.
So maybe after this COVID, one of the things we could do is actually take a physical tour after all this COVID craziness. But we thank you guys. It was good. I think what you just expressed, Dr. Horbinski, is our dream. And I think it's a great place to end this. And thank you guys very much.
Thank you, Dr. Murray. Thank you, Janet.
So nice to see you both again.
Thank you.
Well.
Mm-hmm.
And I found
This was very good, Janet.
Thank you.
You did well. You did.
It's funny. To me, it's always so funny how you feel so strong and then you see those faces and it's so raw still.
Triggers, yeah.
Sorry about the beginning.
You do not have to ever be sorry for that.
My son kept kicking me like, get it together, Mom.
You held it together better than I would have ever been able to do.
I drank the water. I drank water.
Water, right?
And just like, you just think you're like past this stage and it's crazy.
Yeah, no, it's in there. It's in there. There's a lot of really cool information. I mean,
oh my goodness.
Yeah, the one about it being started maybe even in the uterus.
Yes, that's what I came home and told my kids that, and I won't tell you their response about their grandmother.
Okay.
Because we're still public.
All right.
There were choice words there.
But that's scary.
Yeah. You want to stop the recording?
This isn't the only thing. Atherosclerosis actually starts in the utero also.
What?
Yeah, so heart disease actually starts before you're born.
Oh my goodness. Okay. So I'm learning some stuff here too. Wow.
Would I be able to get a copy of the recording once you do it? Because we have a Facebook page for my husband that we have kept going. My daughter has kept going. It's you found it, Dr. Murray. It's
yes.
Desmond's fight. And our dream as a family is to one day do something at Northwestern Memorial in the name of my husband.
Mm-hmm, mm-hmm. Yeah, without a doubt. You know that.
Yeah.
Yeah. See what a humble request turned into.
Yeah.
Very persuasive.
I'm very, very, very excited about the research that you guys are doing. So please
Yes.
publish anything or anything, let us know. My colleague, Dr. Brand, is on, and I'm so excited he was on.
Mm-hmm. Yeah, I think it sounds like they're open for us. Once we do initial studies here, Denise.
Yeah.
Right, yeah.
And we see things that are
We'll
promising.
do the preliminary screening and then send them out anything that looks promising.
Yeah.
And after that presentation, I think chasing invasion is really important now.
Exactly. Exactly. And what's most fascinating to me is that if you walk into, they're on the 21st floor of this building in Chicago, the is cancer, but the neuro-oncology section is by itself. The lab for the pathologists are downstairs. But it's, you walk in and you get this aha moment with the gold brass letters on the wall and the very, very, very fancy offices. And yet they treat you as you're the only person that is there. There's not a 15-minute turnaround. There were times we were there 40 minutes. There were times we were there an hour. It's the value and the compassion that they speak about. In the fall, when Dr. Horbinski met with us at that meeting to thank us for the gift of our families, he started to cry.
Wow.
That moved me so much. He basically said, we see a lab and we do our research, but when we connect the stories of the labs that we have today with the people that they're connected to, it humbles us that you would do this for us. And he just started crying. So it was just, and that's when I saw it with Dr. Lukas too, the many times, like you see the picture of him and Rick where he's holding Rick, because that was the last time he was physically on this earth going to see Rick. Yeah, but Rick's.
Yeah, they really bridge the humanity and the science.
Right.
They really do.
And I hope that's what the students get out of this.
Yeah.
Is they are making medicine human.
That's right.
It's not a mechanistic profession.
And yet they're published authors, renowned, you know, they're world class. I mean, he's talking about Switzerland and he's talking about France and he's talking about all these incredible, and they are the people who volunteered to serve our students today, which is fascinating to me. Anyway,
okay. So I will get this recording to you and to others. Thank you.
I'm afraid of what our next conversation will lead to, Dr. Murray.
I know.
Who else we can invite to your class?
Exactly.
You all have a blessed Sabbath and a blessed afternoon.
Okay, same to you.
Okay, bye-bye.
Okay, bye-bye.
For joining us.
All right.
Yeah.